what happened with the patient, you have to go to the financial sector because they know what happens with the patient, because they know that the patient went to that hospital, that hospital, but as a doctor, I don't know.
I think technology is a really broad term. And I think it can be empowering for patients and it can be informative and empowering for clinicians as well. So we do look to embrace technology in the United Kingdom.
Oi, pessoal, tudo bem? Começa agora mais um Futuro Talks, o programa em que eu recebo as pessoas que pensam, trabalham e fazem a saúde do nosso país. Meu nome é Natália Cuminali, eu sou jornalista especializada em saúde e fundadora do Futuro da Saúde. E hoje a gente está aqui numa edição especial do Futuro Talks, que está sendo conduzida diretamente da Convenção Nacional da Unimed em Campinas. E a gente vai falar aqui sobre a organização do sistema de saúde e a formação do médico. E para isso eu tenho o prazer aqui de apresentar os meus convidados. Quem está aqui comigo é o Rich Withnal, médico e professor e examinador-chefe e diretor médico de Educação e Treinamento Internacional da Royal College of General Practitioners e conselheiro do governo britânico sobre emergências médicas nacionais. Quem está aqui comigo também é o Gustavo Gusso, médico e consultor em estruturação e avaliação de redes de atenção, com foco em atenção primária à saúde, e professor da USP, onde também é coordenador do internato de medicina de família e comunidade e supervisor da residência médica de medicina de família e comunidade. A gente vai fazer esse episódio todo em inglês, então vocês vão poder contar com as legendas. So, let's switch to English. Welcome.
Thank you.
Welcome.
Thank you.
So let's going to start giving our audience some context. We heard that NHS is a huge example for us as a health system. So, and also we heard here that about NHS is in a current crisis. So, Dr. Rich, I want to know the first thing, how is NHS right now?
Well, thank you very much. It's lovely to be talking to you and it's fantastic to be in São Paulo. I think the NHS is in a challenging place. We've recently celebrated our 75th birthday, and it's a real triumph of public health and medicine that people are living about 10 years longer now than they were when the NHS was founded in the 1940s. But because people are living longer, there's obviously more conditions, there's polymorbidity, there's more need for drugs, polypharmacy, and on top of that, we're still recovering from the challenges of COVID. There are millions of outpatient appointments still waiting to be undertaken, and the staff are working incredibly hard to try and get on top of those things. But that does put pressure on the workforce. And of course, it costs more money because we need more capacity to treat that aging population and the COVID backlog. And that's the same whether we're talking about hospital-based care or whether we're talking about community-based care. So yes, there are stories about the NHS being under significant pressure. Mm-hmm. We have had headlines in the newspapers in England saying that there's a toxic environment within the NHS. Personally, I'm not sure I agree with that. I think the NHS does amazing work. It's full of amazing people, but they are under pressure. They're under pressure because of increasing demand, and they're under pressure because actually it would be really, really helpful to have more investment in the NHS to give us that extra capacity.
And how are you working to solve this problem? And how do you see the role of primary care in doing it?
Yeah, thank you. What we're trying to do is move as much care as we can out of hospitals into the community. There's several reasons for that. Actually, it's better for patients. It's much easier to be treated close to where you live. And that's incredibly important when you've got an aging population that might not be able to travel to the local hospitals. From a financial point of view, we know that it's much cheaper to actually deliver care in the communities. So we've been having conversations in the United Kingdom about a new government initiative for new hospitals. The plan was to build 40 new hospitals. Well, we may well need those. We need the hospital capacity as well. But if you were to take that amount of money and invest the same amount of money in community-based care, then the evidence suggests that actually at the population level, you would get better health outcomes. The other thing that we're learning is that it's a little bit like football. Community care is a team sport. And there are lots of different people on a football team that all have different roles. And when they work together, the team is successful. So as well as moving care from hospitals into the community, we're trying to work with our colleagues in the multidisciplinary team, empower our nurses and our pharmacists and our physiotherapists and other colleagues to take on more responsibility for patient care and work in very much a multidisciplinary team way. And if you do those two things at the same time, the outcomes are very good. There's evidence that in chronic diseases, if they are managed by expert nurses, the outcomes are better than if they're managed by doctors. And as I've mentioned, it's preferable for the patients to be treated close to home in a community setting.
Great. Dr. Gustavo, I want to invite you for this conversation. And thinking about the Brazilian reality, we are facing, I think that's same as well, NHS, because of COVID and other things. And I want to hear you about the whole of primary care here in Brazil. And actually, I know that it is different in public sector and private sector. And could you bring us insights about it?
Yeah, thank you. I think we have similar challenges, which is actually new money. It's a challenge all over in any country to find new money to fund the health system. And we have the pharmaceutical industry doing so much, so trying to push more things into the system. So the money is we have the same we call in Brazil pizza. So we have to fight for the budget, and I think this is in anywhere. But I think we have to take the different crises into consideration, because I think the NHS crisis, it's a crisis that we would like to have, if Brazil has this crisis, because they see everybody, they have a system that the legacy of the NHS is amazing. So they have a crisis because they are comparing with the situation before. So we didn't reach this situation where with our system we have the public and the private, and we didn't organize that much. We don't have the primary care very strong in the private. We do have primary care in private. Somebody say we don't have primary care. It's not a choice. Primary care is access, longitudinality, integrality, which is comprehensive care actually, and health coordination. So we do this, but sometimes we do bad. But it's not something that we don't do. It's not yes or no. We do in any, even in private, but we don't do really good. So we have to strengthen the primary care to reach their crisis.
And do you think that private sector is getting more interested in investing in primary care?
Yes,
is that a trend there or no?
Yes, but it's there is ups and downs, and nowadays the name primary care, that's not that in there 10 years ago it was a hype. Primary care. But I think the private, especially in the private system, sometimes I think there is one hope for one solution from one magical solution. It doesn't happen. And primary care it's done by doctors, by nurse. So it's there. We have to organize. And if we don't want to call this primary care, it's not mandatory. We can call we can create another name. This is not a question of name. This is a question of the system. The system needs the patient need one journey that they can find the right doctor at the right moment and the right place. So primary care helps this, and primary care helps to distribute better the money.
It is important to think because we have a growing population that is getting older, so we have to to organize the system. And you mentioned in your answer about the pharmaceutical industry getting new treatments and investing in bringing new treatments, and this is expensive. And I know that NHS has a system, I think that's nice, the name, that sees and analyzes the new treatments. Can you give us a little about how it's work?
Sure. Yeah, so in the United Kingdom, we actually have 4 different NHS organisations. There's a different organisation for each of the 4 countries of England, Scotland, Wales, and Northern Ireland. And NICE is one example, but there are others as well, whereby we are given as clinicians guidance on what the evidence base is. So there is a professional team that will look at the range of opportunities that are available, and they'll take a number of factors into account. Clinical efficacy is at the top level, but they also have to weigh things like cost. And they will come to a judgment about what is appropriate to be given out across the NHS. And they publish guidelines which go to all of the clinicians with particular criteria that would need to be met to enable that, if it's a medication, that medication to be brought into practice. There are parallel systems in Scotland. They're called sign guidance, for example, for medications. But I would also say that there are other bodies that now work to consider new technologies that we might want to bring in as well. Because increasingly we're seeing the value of how technology can help decision support. And when one has that decision support, then things like the NICE guidelines are there to then point us to the right direction. And what we're trying to do is bring those two things together. So we have electronic platforms that we do our consulting on and we record our records on. And within some of those platforms, the computer will actually give us the guidance of what the best evidence is that's approved by NICE, for example, so we can select that option for the benefit of our patients.
And how this helps in the making the system sustainable?
Okay, yeah, it helps in 2 ways. It makes it sustainable in terms of patient care in the sense that it shares best practice, so it becomes standardized. There are occasions where clinicians can act slightly outside of guidance if there's a reason to do that, but they have to have a good reason to go outside of the guidance. And it also makes it more sustainable because one of the considerations is cost effectiveness if things are rolled out at the population level. So the combination of that clinical efficacy and affordability add together to make the treatment sustainable.
And Dr. Gusso, you said that we are far away from NHS crisis. Like it would be great to be there. So how do you see the whole of technology on helping us to get more effective in getting there?
Well, it's a good question. I think the relation that I always do with technology, because of that magic solution that sometimes we hope in Brazil, we are very religious people though, so
Yeah.
we really think that maybe the solution comes sometimes from the sky, you know. So this is dangerous, and technology might fall in this area that it's a tool. It's a tool. It's like a chair. You can use to sit or to throw in somebody's head. So it can be dangerous as well. So the technology, especially the telemedicine, the video consultation, this kind of stuff, we should put into in the context of the health system, and in one area that we should integrate with the face-to-face consultation, for example. So if we include this technology just as one other access, not connected to the system, it will be a problem. It would be other access to, maybe it would be the wrong patient and the wrong with the wrong professional in the wrong time. So it's not the magic solution, and we should take care when we go to include this. You know, even in our life, We
Mhm.
use WhatsApp. Sometimes we use good. Sometimes it gets us too anxious.
Yeah.
So sometimes it comes from for a better communication. Sometimes it comes from worse. It makes communication worse. So
Do you
this
think
is
that we are in a good way
include.
using technology in healthcare?
I think we are in the way to use. Well, Brazil is very diverse, so we have to see. In general, I think yes, we are trying the best, but it depends in each local organization if they are getting this integration between the technology and what we have. We are facing challenge to integrate data from hospitals and from primary care. This is a challenge all over the world. We have now the law that protects the data, which is very good. But this is not a barrier. I think the barrier is the biggest barrier here in Brazil, which is different from there, is to agreement between people. How is the best way to make the data goes from the hospital to the uh, because everybody wants to be the owner of the data. Here in Brazil,
Mhm.
so the data is mine, the data is there. So they fight for the ownership of the data, which is not good. The data belongs to the patient, and we should use the data for their benefit. That's the final proposal of the technology. So uh, we should not to have that much problem to discuss who owns the data, but we should work to benefit the patient and the health professional that are working for the patient, because sometimes here in Brazil, if you want to know what happened with the patient, you have to go to the financial sector because they know what happens with the patient, because they know that the patient went to that hospital, to that hospital, to that hospital. But as a doctor, I don't know. I don't know that the patient was last week in hospitalization. And the patient, they don't, it's not that they don't want to say, they don't remember everything. It's difficult for them to remember all the exams that they did, all the consultations that they did. So it was very good for the patient if we could integrate better the data and in a way that benefit them.
Dr. Rich, I want to hear you about it, about the use of technology first, and then how are you using the data?
Yeah. I think technology is a really broad term. And I think it can be empowering for patients and it can be informative and empowering for clinicians as well. So we do look to embrace technology in the United Kingdom. And probably the term that sums that up best is decision support. So we're starting now to be able to do in the community things that traditionally we would have had to send patients to hospital to do. And a good example would be monitoring of blood sugar levels in patients with diabetes. So previously, they would have to go to see their clinician to have a blood test done, and they'd wait for the result, etc. Now we have sensors that people can wear, and they can track their own blood sugar levels on their mobile phone. So it's empowering for them, and they can make corrections when they start to see things happening. If you're an older person, for example, there are sensor technologies that we can use to support them, and those sensors will send alarms if something goes wrong or the patient falls over, for example. So at that level, it can be very empowering and it can drive decisions. Sometimes that the patients can then do things for themselves, other times to alert the clinicians. I think Gustavo's point about data protection is very important. And we are still striving for an elegant solution where, with the right permissions, everybody can see the right sort of data. And I like Gustavo's phrase about putting the right doctor in front of the right patient at the right time. I think actually in the UK, we would say it's putting the right team around the patient at the right time. So that team may include a nurse, may include a doctor, might include a dentist. There are some things in the medical history that my dentist needs to know about me. Perhaps if I'm allergic to antibiotics, there are other things that the dentist might not need to know about me. So it's having a good situation where all the data is available, it's accurate data, but that data is protected, so the people that need to see it can see it. And of course, the other thing that's excellent with technology is we can now have telemedical links between primary care and secondary care. So again, if our general practitioners need advice, let's say it's a rash, they can take a photograph, they can send it to the consultant dermatologist at the hospital, who can offer advice and send it back. The patient doesn't necessarily have to wait and then travel to the hospital. I suppose the final thing that we're thinking very hard in the UK about at the moment is artificial intelligence, and how artificial intelligence could help us both diagnostically, and how by learning through artificial intelligence, perhaps it could inform the guidance that bodies like NICE and others do at the moment. And there's an excellent case study that's been published from the United States about a child who had a very, very rare condition and had been seen by a whole series of experts in different specialties, but nothing really added up, and none of those individual experts could make the overall diagnosis. When they put it through an artificial intelligence algorithm, actually they pulled all the relevant bits of data together and they came up with a very rare diagnosis. So I think it's inevitable that artificial intelligence will have a bigger influence on medicine. I think our challenge as clinicians with our managers and our other colleagues is to make sure that that's used in an appropriate way.
And are you already using AI in UK?
Yes, we are. I mean, there's some examples now where actually artificial intelligence is better than the human eye. So for reading things like mammography, so breast x-rays as part of our national screening program, and for looking at lesions on the skin, melanomas, the evidence suggests that the artificial intelligence algorithm is better than the human being sitting trying to read those. And I think with time, we'll find more examples like that.
Dr. Gustavo, how do you see the use of AI here in Brazil? And do you think that we are ahead?
Yeah, we are trying the same for example, to the breast cancer diagnosis, this kind of stuff. I think it's a reality in Brazil as well. But in everywhere, I think we're trying to understand what's the best way to use. I use in my practice, for example, for diet. Some patients say they have a special diet. I use to for special disease, for example, sometimes, or to consult something. But we can use in very different ways. I was in a meeting next month in Spain about communication in health, and there was one guy who showed one study that they are using AI to give feedback for the doctors about how they communicate with the patient. So instead to expect that the AI get more empathy than the doctor, we can use the AI to get the doctor better empathy, because we have our non-verbal communication. So this is not the good way to go to replace totally the health professional. But we can use the AI to be better health professional, and to not to for example, I don't need to know everything anymore. I can consult the AI sometimes. This is very good. So we really should use AI for our benefit and for the benefit of the patient, and to replace some of our tasks and to get our life better, to save time. For example, we can use AI in the electronic health record a lot sometimes. So we are learning how to use this. And as I said before, it's a tool. And I think it can be dangerous as well, of course, even for patients if they are not, if they use without a guidance, or maybe the reference, they are not quite accurate sometimes. So we have to learn, and I think everybody's doing that. And I think we are going to succeed not only as a doctor, as a woman being.
And thinking about the future, and not just about AI, but all the future of healthcare, how has medical training evolved, and how can we prepare these new doctors for this future, Dr. Rich?
I think that's a great question. I mean, our students of today are the doctors of tomorrow, and we're all patients as well as clinicians. I think it's inevitable, and actually, I think the future is very bright. I think the generation of students coming through in the UK have grown up with technology. They're much better than my generation were. They can hold parallel conversations on two different mobile phones all at the same time. They are used to using technology to support their choices already. And I think they are perhaps less frightened of technology than some of the older people. But Gustavo's just made a really, really interesting point. The amount of data and the amount of platforms available to our students coming through now is increasing exponentially. Things go in and out of fashion very, very quickly. So I think we've got to be minded of what the evidence base is that sits behind things. And just to repeat your point, in students using artificial intelligence, they have to be cognizant of the fact that AI is only as good as the information on the internet that it's drawing from. And that's not always right. So I do think that the students of today still need the clinical skills that they've always had. But I think they will benefit from the decision support from the technology. The other thing that I would add, and we're thinking about this very hard at the moment for our family medicine licensing assessment, is that I don't think we can hide from artificial intelligence. It will happen. Students will use it. It has challenges in exams to make sure that actually everyone is being fair to each other. But rather than try and stop students from using artificial intelligence in answers, we should be embracing it. And we're thinking hard about how can artificial intelligence help us to write good questions to ask in the exams about the sorts of thing that's important. So I'm very excited by the future. I think in 10, 20 years' time, the things that we're discussing today will be very outdated. They'll be obsolete because things are moving so quickly. So we need to embrace that, and we need to use our students, if you like, to help us as the clinicians of today to decide which bits of technology are really good and where we need to be careful about technology. And my final thought is absolutely, as Gustavo has said, we need to be really careful to train our students about data protection and who can see which information when, to make sure that we have that professional confidentiality that our patients deserve about their healthcare records.
So my last question to you, Dr. Gustavo, is how do you see the future of healthcare, and what kind of trends we need to pay attention?
Oh, I am optimistic about the future. Sometimes here in Brazil, we are getting better and better. We should go faster to the future. This is our problem, but I am very optimistic, and I just want to get a relation between the technology and primary care, because we have a very difficult because our system sometimes is that not organized. We don't have clear primary, secondary, tertiary care for the patient. Patients sometimes they use the system in a chaotic way, and we sometimes we hope to do much that the technology will we say now we have technology, artificial intelligence, so we don't need to take care, don't need to organize primary care because it will replace that. This is not the way to go. So we have to take care about this, and then we really should keep the principles of the system very strong and put the technology into these principles, which is the patient-centered, the multidisciplinary team, and all this stuff. We should train the students for this, which is a future, but this is actually something that we should try now. So maybe the future is something that we didn't get now, and we are going to implement in the future. So the future is sometimes, I don't think the future is something very different. We are going to live in a Jetson's world. I think the future, we are going to have things that we would like to have now.
And how do you see, Dr. Rich, the future of primary care?
Yeah, I think primary care will grow. I think it has to grow because there are capacity constraints in secondary care. And I think the interface, things like using technology for near patient testing So you don't have to send samples off to laboratories which are remote. You have techniques of doing those in primary care and getting results straight away. I think that will be a really exciting thing about the future. And therefore, our next generation, our students coming through now, may need skills that we haven't had because we've done things in a different way. So I think the future is very bright. I think we should embrace technology, and I think that will help patients.
Great. I'd like to thank you so much for the interview and sharing your insights. Thank you so much.
Thank you.
Thank you.
Thank you. Muito obrigada a todos vocês que acompanharam o nosso episódio. Se você ainda não assina o canal, não se esqueça de assinar. Até mais.